Hi everyone. In this video, I would like to discuss about hyperkalemia. What is hyperkalemia? Hyperkalemia refers to abnormally high levels of potassium in the blood. In normal circumstances, more than 90% of total body potassium is intracellular. The remaining is in extracellular fluids and blood plasma. The ratio of intracellular to extracellular potassium is very important to generations of action potentials for normal functions of our neurons, skeletal muscles, and cardiac muscles. So, this is why potassium level in our blood is strictly regulated with a narrow range between 3.5 to 5 millimole per liter. As our normal dietary intake of potassium varies widely and can be as much as 100 millimole per day, the body must be quickly and precisely react to keep our blood potassium within the normal limits. This is achieved by two mechanisms. It's through excretions of the potassium through the kidneys and intestines, with the kidneys plays the predominant role. Shifting of potassium from extracellular fluids into the cells by the sodium-potassium pump. The pump is mainly regulated by hormones such as insulins and catecholamines. Hyperkalemia is defined as serum potassium concentrations higher than 5 millimole per liter. Hyperkalemia may result from first, decreased renal excretions. Second, increased potassium load. Third, increased release from the cells. And lastly, pseudo-hyperkalemia. I will elaborate further on the causes of hyperkalemia. For the decreased renal excretions, the causes might be acute renal injury or drugs such as potassium-sparing diuretic, ACE inhibitor, the use of NSAIDs, or the patient states of acidosis and Addison's disease. Next is increased potassium load. The possible cause of increased potassium load is massive blood transfusions or excess potassium therapy. Furthermore, increased release from cell, such as shift of potassium out of cells in acidosis state, diabetic ketoacidosis, and aldosterone deficiency, or tissue breakdown in digitalis toxicity, rhabdomyolysis, tumor-lysis syndromes, and tissue necrosis or crush injury. Last but not least is pseudo-hyperkalemia or artifactual result. The possible causes are hemolysis, contamination of potassium EDTA anticoagulation in full blood count tube, or delayed analysis. Most common scenario is renal insufficiency combined with excessive potassium supplement or administrations of certain drugs that may aggravate hyperkalemia, as I mentioned earlier, such as potassium-sparing diuretics, ACE inhibitor, and NSAIDs. Mild hyperkalemia usually without symptoms, although some patients may develop muscle weakness. This is because slow or chronic increase of potassium levels is less dangerous, as the kidneys will eventually adapt by excreting more potassium. Rules: sudden onset and rapid progressions of hyperkalemia can be fatal. Primary cause of mortality is the effect of potassium on cardiac functions. As potassium level increase in extracellular space, the magnitude of potassium gradient across the cell membrane is reduced, and so the absolute value of the resting membrane potential. The membrane voltage become less negative. It's moving closer to the threshold potential, making it easier to initiate an action potential. This will increase myocyte excitability, further rise the potassium, have the opposite effect. This is because the value of the membrane potential and the onset of the action potential determine the number of voltage-gated sodium channel activated during the depolarization. As this value becomes less negative in hyperkalemia, the number of available sodium channel decreases, resulting in slower influx of sodium and subsequently slower impulse conduction. So, here is ECG changes produced by hyperkalemia. It follows a typical pattern and correlates with serum potassium levels. The characteristics are tall tented T waves, small P waves, depressed ST segments, QRS complex widens, and sine wave presents. So here comes the last part of our discussions on hyperkalemia, which is the management of hyperkalemia. The goals of treatment in hyperkalemia is first, to protect the heart from the effects of potassium by antagonizing its effects on cardiac conduction, as it can cause mortality. Second, to shift potassium from extracellular fluids to intracellular fluids. Third, to reduce total body potassium. The treatment options that we have to treat hyperkalemia are calcium administrations, glucose and insulin infusions, beta agonist therapy, sodium bicarbonate infusions, cation exchange resins with calumet or resonium A, diuretics, and last but not least is dialysis. The treatment of hyperkalemia depends on the severity of the hyperkalemia. For mild to moderate hyperkalemia, which the potassium levels is 5.5 to 6.5 mmol per liter with no ECG changes, you can advise on low potassium diets, stop the drugs that can cause hyperkalemia, give cation exchange resin therapy, correct the acidosis in patients with metabolic acidosis, with or without glucose and insulin infusion. As for severe hyperkalemia with potassium level of more than 6.5 mmol per liter, with ECG changes, the treatments of choice are all the treatments given in mild to moderate hyperkalemia as stated previously, immediate calcium administrations, glucose and insulin infusions, sodium bicarbonate infusions, beta agonist therapy, and if all the other treatment is failed, you might need to consider dialysis. It is important for us to recognize the characteristic of hyperkalemia on ECG to help us for early diagnosis and early treatment to avoid further complications. That's all from me. Thank you.